Hello, everyone. Welcome. Thank you for making the time available to join us today on this sunny Friday morning. It's sunny where I am, and I'm hoping it's sunny where you are too. For what I hope will be a really thought-provoking and interesting discussion about a very timely and important issue, which is neighbourhood health services. I'm Ewan King. I'm the chief executive of a charity called Shared Lives Plus. We are responsible for the Shared Lives community around the UK, but I'm also soon to be in September, I should say, the chair of the Care Provider Alliance, which comprises 10 umbrella organisations, representative organisations that support the adult social care sector in England. Yes, as I've said, today we're talking about neighbourhood health services. And if anyone was watching the TV yesterday, you'll have seen that Wes Streeting, the Secretary of State for Health and Social Care, was talking about the importance of this idea of neighbourhood health services. We fully expect this concept, this idea to feature strongly in the 10-year plan for the NHS, which the government is currently developing. We'll hear a little bit more from our colleague Tom Riordan, who's going to talk to us about where the government's thinking is on this. And we know that it will feature heavily in whatever vision, I think, emerges from the Louise Casey review of adult social care, because we know that in order to develop sustainable health and social care services, we're going to have to bring more services into the community, closer to people's homes, coordinated and personalized around the different needs of people within communities. So it's very much part of the future vision for the government. And of course, there is very good practice already happening across the country, in many parts of the country, and we're going to hear about some of that good practice today. But we know we need to do much more to develop really good integrated neighbourhood health services locally. So today we'll have an opportunity to talk about many of the issues relating to this. How do we get the leadership to work effectively locally? How do we involve communities, people who draw on care and support and health, involved in decision making within neighbourhoods? How does the money work? How do we commission the right kind of services and support within neighbourhood areas? How do teams comprising OTs, social workers, GPs, nurses, how do they work together effectively at the local level to support people in an efficient and effective way? So there are a whole host of questions that I'm hoping we can touch on today. On the screen in front of you is the agenda, and as you can see, we've got some wonderful and very well informed speakers who will talk to you about neighbourhood health services. What do the foundations of good neighbourhood health services look like, and how do we build upon those? So I'm really excited to talk to you and to introduce those speakers shortly. Okay, and just to say, we've had some questions from you all sent in already, and I'll try to make time to ask our panel some of those questions, but do keep coming with questions. So there's a question and answer function. Do just post your questions. I'll be able to see those, or my colleagues will be able to see those, and hopefully we'll try to answer as many questions as we can within the next hour and 20 minutes. And also we will be producing a recording, and we will be circulating slides from today's session. So don't worry, you won't miss anything if you have to leave a little bit early. I'm going to kick off by asking our colleague Tom Riordan to just give a sense of where the government's thinking is going on this. Not everything is laid down in stone, of course. There's a plan that's being developed at the moment, but Tom will give you a bit of an insight into where the government's thinking is on neighbourhood health services. But also Tom was previously Chief Executive of Leeds City Council, and Leeds has a fantastic track record in bringing together health and social care at neighbourhood level, so he may well touch on some of that as well. So Tom then has to leave at past, but hopefully we've got a bit of time with Tom to hear from him and ask him some questions. So thank you. Tom, I'm going to hand over to you if that's okay.
Thanks, Ewan. Thanks for the opportunity today. Great to see everybody and not see some of you, but hopefully you'll enjoy the session today. I'm really sorry that I can't stay for longer because Melanie, Robin and Luke have got some fantastic examples of, I think, good practice and insight into how we can make this work. The caveat I've got to put at the front of all of this is, of course, that as Ewan said, the 10-year plan is a work in progress. We're just coming to the end of the engagement and consultation process, which has been very different and innovative, much more in depth, I would say, than lots of consultations that I've been involved in before at both the national, regional and local level. And it's been incredibly powerful to hear firsthand from citizens, from workforce, from the partners, directly, and also to hear them debating and discussing the trade-offs that we get into with some of the wicked issues that we're trying to deal with here. But yeah, it is a work in progress. So what I'm giving you is my sort of best personal view about where we are and where we're headed. I think, as Ewan said, clearly neighbourhood health as an idea is something that is gaining ground and gaining traction, and I think it's a really big opportunity to be almost the vehicle for reform that can galvanise people together on the front line with citizens and patients in mind, and try to break down some of those cultural barriers that we know exist between different organisations, the NHS itself and other sectors, not least social care, home care, local government, etc. What we've done already, you'll have probably seen, is published some guidelines at the end of January, which set out the broad idea and framework. And there's a diagram in that guidance that is worth keeping in your mind when you're thinking about neighbourhood health. And it's 3 interlocking circles, and at the centre are basically hospitals and care institutions. And the basic, principle is, how do we prevent people ending up in those institutions who don't need to be there? The second circle is what you might shorthand, and it doesn't tell the whole story, but it helps get it across. Basically, out of hospital health and care. How do you bring together in a more coherent way, particularly around GP access, but also community health, mental health, social care, public health, home care, etc. How do you bring that quite atomized system together in a more coherent way to meet the needs of individuals and families and communities? And so a big part of neighbourhood health will be, I think, and the early work will be about that second circle and about how we do that. Because at the moment, any of us who've worked in that space will know that you almost work together despite the system sometimes, rather than because of it. And that's what we're trying to flip the model and the thinking, so that it just becomes much more easy for people to work together in the interests of people, of citizens, in a person-centered way. And then the third circle, the outer circle, is represents the sort of wider public services, and the fact that probably 1 in 5, 1 in 4 different research comes out with different numbers, but broadly quite a big proportion of people who end up talking to a clinician, either in A&E or in a GP surgery or elsewhere, will probably need, rather than a medical intervention, something like, advice about debt and financial problems, opportunity to, tap into local community networks, maybe befriending or loneliness type issues. What you might call, and I don't mean this in the wrong way, I've lived in my family with mental health for all my life, so I'm a very big proponent and supporter of improved mental health services, but what you might call, not acute, but lower level mental health issues where people need some help and support, but not necessarily any medication. And jobs and skills, housing, all those wider set of almost social determinants, but also public services that it's incredibly complicated to navigate your way through, even if you've got through the health system first. So that's the principle. How do we do that is really the next stage. There are two things I would just say in then maybe opening it up to discussion. The first is that obviously the 10-year plan is where we're trying to crystallise this, and that will be looking at the whole range of different issues. It will be looking at the issue of estate and how services are quite fragmented, and it's quite difficult to, referrals often take quite a long time, and it makes it difficult for people to get the support they need at the right time in the right place. So is there a model where, you might think about neighbourhood health centres? We might have some of them already. You might even hear about some of them already in the presentations that we hear about, because lots of councils and health partners have been working on this agenda a lot. Secondly, financial flows. So at the moment, the finances of the NHS don't quite fit with what I've been talking about. So is there a difference there that needs to happen? The ability of the different organisations, particularly in that out of hospital space, to work together and to work in a way that where commissioning helps drive that population health and almost a cohort approach, you might say, to thinking about the those people with complex needs, for example, who really need that intensive support. And it will also look at data sharing. One of the biggest differences we made in Leeds was when the hospital staff and clinicians, the social work teams, the home care workers and others were able to see real-time case data of an individual who was coming out of hospital. And rather than spend their time ringing each other up or sending emails that weren't being answered or trying to navigate meds or transport out of hospital, you could have that sort of real-time, real connected, integrated neighbourhood teams, you might describe it as, that could make a big difference. So there's all that work that we're thinking about. And social care is crucial to this. I know there's a debate, and I know that, people have been concerned that how can you do a 10-year health plan without dealing with the social care issues at the same time? Now, there's good reason why we've got Baroness Louise Casey doing the work that we've set out on, because it needs somebody of that calibre and stature and influence, I think, to win over lots and lots of people to a way forward. But that doesn't mean to say that the world doesn't stop turning and that we can't do reform and make changes immediately. Indeed, Louise will be in the loop on all of that stuff. So there will be this. The way I would describe it is that the landing point for social care in the 10-year plan will be neighbourhood health. That's the way I would describe it. So be ready for that, and let's engage with it in a positive and asset-based way would be my suggestion. And then finally, we are going to have a national improvement programme that will be launching soon, that will be led by somebody called Sir John Oldham, who some of you may be aware of, has done lots of work over the years on GP-led community health integration very successfully. and it'll be a joint approach between the newly merging NHSE and Department of Health colleagues. And what we'll be trying to do is work with every ICB in the country to identify good practice and work with a part of their place, which will enable us to sort of learn together to look at what is good practice and try and scale it up. And if it can't be scaled up, try and remove the barriers to that and start a bit of a movement, I would say, involving not just health, but social care, home care, public health, all sorts of partners. The VCS sector, absolutely critical to this agenda. If you think of those three interlocking circles, you know, the work we did in Leeds, we were blessed to have a fantastic VCS sector. And if I was trying to get people volunteering in Leeds, they'd never volunteer for something badged as Leeds. Well, they would, but it'd be much harder to get them to volunteer for something badged as Leeds, let alone Leeds City Council, because they'd say, that's why I pay all my money for that stupid Tom Riordan to spend it on things he shouldn't. And then actually, if you did it as a Kirkstall, you know, Holbeck together, whether it be for older people, Armley Helping Hands, you know, then you get someone like the local landlady of the pub who's just retired, or the police officer who's just retired running the local charity. Absolutely fantastic opportunity for people to link in to help people stay out of that central circle and live independent lives and fulfilling lives, which is what we want. So I'll finish there, Ewan, and hopefully that has painted a picture of the opportunity. We're all ears at the moment, so if you've got any things you'd want to send in to us at the department or NHSE, we're really keen to hear from you.
Thanks a lot, Tom. And Tom is absolutely right, by the way. At the moment, the DH is actually very open to, DHSE is very open to ideas and suggestions. I found that when I'm engaging with civil servants in the department. So do take them up on that offer of sending in your thoughts and ideas to the department. Okay, so there's quite a few questions that have come in. One question is around the community assets that we have around care homes. So we've got 17,000 care homes across the country. Is there an opportunity here to invest in those care homes so that they become hub and spoke outreach type services, so that they're more than a care home and they provide a greater range of services to the community? Any reflections on that, Tom?
I think that's a really interesting point, because I think I think we have been pigeonholed a bit in this sector at times. And when you think about, I mean, my mum's in a care home. She's been in a care home for many years, and they provide fantastic support for her. And sometimes it's more from a just dealing with care to more of a sort of dementia care service. And I think the more that we can think how more laterally about the assets that we have in a community and the role that, you know, assets like care homes play, I think that's a really interesting question. I don't have the number one answer to it straight away, but I think a lot of people, particularly if they've had elderly relatives who've passed, who've been in those care homes, they feel a bit of a connection to them as well. And they can maybe, I think this peer-to-peer idea is really interesting about how we can get more support, you know, for people going through similar issues. So yeah, no, I think that's a really interesting question.
Thanks, Tom. So perhaps a little more tricky, this question. It's about how at a neighbourhood level we enable people to access both health and social care when those services sometimes are free at the point of use and sometimes aren't. And I know in Leeds you probably had some ways in which you were able to enable people to access most services. Any insights on how the financial flows might work to support that kind of equal access?
Yeah, I think it's obviously, you know, we have two different systems where, you know, one is means tested and the other one is free at the point of use. I think, you know, as Wes and the government has been really clear, free at the point of use is there to stay, and that's a fundamental pillar of the NHS that I think is one of the reasons why people feel so strongly about it and believe in it. But how you ally that with a system where we've got to come up with something that's affordable but fair as well, is a really, it isn't straightforward, and it's one that Louise will be looking at really carefully. I think there's probably some areas where we could do better of working together, and maybe I do wonder whether more regularized approaches to certain levels of service might be a better way to operate at times, having gone through it ourselves, and the time that it takes to negotiate and run through certain things. Whereas if you had more of a standard offer that we could use, that might be one way to run through. There's lots of tensions and issues around Section 117 and issues like that. There are issues about transition as well from children's social care to adults, particularly people with disabilities who become of working age, and how we can get them better linked into work and health. So initiatives. So yeah, I don't have an answer to that, but it is one that we're actively looking at.
Fantastic. There's also a question about the upskilling of care workers and how that could align with the vision for neighbourhood services. So that's about more people being able to take bloods, for example, undertake medical procedures, just basically share the medical burden and activities across a wider group of people. Any thoughts on how that might work?
Yeah, I mean, I'm a big supporter of this. I think the sector, social care has been, that we haven't told the full story of the amazing work that happens in social care, and because it's such a challenging area with massive, financial challenges and a model where the market just hasn't quite worked as it should do for such a long time in places, that we've sort of, I think, undervalued social care. And I think telling that story and telling the story of the compassion and the care with which carers and unpaid carers, the role they play in society, the fact that it's a mainly female workforce, that it's a workforce that cares for some of the most vulnerable people in society. Having experienced it myself, the work people do is incredible. So I think trying to give a better career structure to people in that sector, trying to think about how we can graduate from being a care worker to a manager to a more specialist role, and then to become in the sort of senior management, I think is something we definitely, is really, really a good step forward, and one that Wes was talking about at the Unison conference this week. I also think the fair pay agreement and the direction there is, if you like, the end point that we're aiming for, that we need to get ready for. So I think there's lots in that space, and delegated tasks, as it's called, I think is definitely part of that. We need to make sure people are paid fairly for doing that, and we also need to make sure that there's a quality and safeguarding element to that, which everybody can be confident in. But in principle, I think that's definitely the space that we need to be moving into as we move forward.
Thank you. A couple of questions are coming around how do we shift power away from organisations, statutory organisations, towards the community, so the community has a greater say in how things are delivered locally. What do you think works in that space? I know you've done similar things in Leeds to build in the voice of communities into decision making. How might that work?
Yeah, I mean, I pushing back from a bit of pressure we had, actually. I was always a very strong advocate of having the sector, the VCS sector, round the table, if you might like, the top table, with the statutory organisations. And so we we did that throughout all our governance in Leeds, and it rarely, I cannot remember a single decision where we had to say, "Oh, can you please leave the room because we've got to talk about something." I think you can make it work, and I think there's a sort of governance element to it. But the more powerful one is, I think, a more principled one of when you get a council, particularly, and elected members, and a VCS sector who sort of respect each other's roles. Sometimes there's a tension between who's the voice of the community, the mandated elected politician, or the representative of an army of volunteers and a charity in the local community. There's room for both, and you've got to find a way of working where both can work together. So I think a lot of it is about creating the culture, which we did in Leeds, whereby we really valued each other and we respected each other's roles. And it's that sort of, we had a team Leeds ethic, where the important thing was what was happening to the people in the city, not our institutions. And it's hard sometimes to throw that off, especially when there are contested issues. But I think that's what we've got to aim towards.
Thank you. I know you've got to go soon, Tom. So just in terms of other thoughts from people, there's a lot of commentary around the integrated boards sometimes feeling quite distant from communities, from social care in the past, and also the need for a very broad approach to include housing, community pharmacy, all self-funders, volunteers. So there's pleas for this to be quite wide-ranging. How might that local governance and leadership work best, do you think, to make neighbourhoods thrive?
Yeah, I think I always favoured the upper tier local authority because a lot of statutory responsibility sits at that level, and it's the way a lot of other services are commissioned and organised. I do favour that as the connection point, if you like, between the strategic commissioning that needs to happen and then how you get it to work together with the local public services. But actually, the place it really comes together is neighbourhoods, and so I think there's some really interesting models about commissioning that I think Greenwich have done. I know Leeds is trialling it at the moment, and others. There's some great examples in Birmingham. I don't know if Robin's going to talk about that later, and I'm sure Melanie and Luke might touch on this stuff. But in Leeds, we sometimes had wards of about 30,000 people where there'd be 40 different providers crisscrossing each other to serve a local community. Whereas if you can commission for 2 or 3 per ward, then you get people who know the patch, they know the local VCS, they know where the housing services are. You probably attract people who are more local to some of those jobs because they can walk to work, especially if they're not being paid for travel time. The whole thing, the carbon impact of that, it does logically make a lot more sense. So I think that's the area I'm really interested in, about how we can think about that neighbourhood level for how we're going to organise ourselves and services. I'm not sure you need an extra governance at that neighbourhood level. I think as long as you've got the governance at the top, at the upper tier level and the strategic commission level, that's fine, and you've got VCS represented there. In terms of I think that more localised level is just about getting on and doing it and making sure you've got feedback loops if things aren't working.
Fantastic. Okay, I think we need to let you go, Tom. Well, thank you very much for your time today and for your thoughts on Neighbourhood Health Services. I'm sure we're going to hear a lot more from the government department about this in the near future. So thank you, Tom, and have a good rest of the day. Thank you.
Thanks, Ewan. Great to see everybody. Thank you.
No problem. So moving on, we're now going to hear from my colleague Melanie Weatherley, who's also sits on the Care Provider Alliance and is been involved in the provision of social care in Lincolnshire for many years, but also has a national role as well. And she's going to talk about what she's come across in Lincolnshire. So Melanie, do you want to come on.
Thank you very much, Ewan, for inviting me. And it was good to hear Tom say how important social care is to the delivery of neighbourhood health services, because one of my concerns is if we don't talk about that enough, some of our colleagues may reinvent home care, mental health care and support, and other aspects of adult social care. So I'm just going to talk to you about what happened in Lincolnshire. So if we go to the next slide, please, Rachel, that would be great. And we don't have any formal joint commissioning. Going the wrong way, I think. But what we do have, particularly on the east coast of Lincolnshire, we have a very rural area. It can be 8, 9, 10 miles from one house to another, which is a problem for home care and for district nurses and GPs. The level of demand is very high. We have a deprived permanent residency, shall I say, but also there are lots and lots of static caravans in between Mablethorpe and Skegness that you can buy very cheaply. And people who've enjoyed a fantastic holiday when they were little from the West Country or from Derbyshire often retire to the coast, but it's not quite the same in the dark of winter. The level of mental health deterioration is huge because it's very lonely in a caravan site when the main bits are not open. And often they arrive with 3, 4 or 5 comorbidities. And the reason we do it, that's why we have to do it. And the fact that we don't have very many workforce. All the way down one side of our catchment area are some beautiful seals. They're lovely to look at, but they don't make very good care workers. And I'm told they make absolutely rubbish doctors. So we don't have a workforce anywhere throughout the system. But what we do have, we hold on to. So there is a stability in our workforce. Because Lincolnshire, I'm not a yellow belly. I wasn't born in Lincolnshire, but it's quite addictive. It's a beautiful place to live. And it's a very nice work-life balance. The pace of life is slower than it is in a lot of cities. But also it's so cheap to buy property here that once you move here, you can't afford to go anywhere else. So the people in the health and care system tend to be the same for years on end. So you get to build trust. And I do understand that that's probably one advantage that a lot of our colleagues don't have. So we've been doing neighbourhood health for at least the last 15 years. And I only know it's 15 years because that's how long I've been involved in it. We've called it all kinds of names and all kinds of frameworks. And it's been bottom up, it's been centrally led, it's been let's do this, but don't tell anybody because you weren't supposed to work together. But it's been basically the same. And the way it works is primarily on relationships. You have to trust each other because you have to have each other's back. And the way that works is that we don't have any co-located services because a lot of people are still working from home. But what we do is every week we meet together virtually. So we co-locate on Teams, if you like, and then we have regular open days and come and see what's the voluntary sector offering today, what does the district nursing team want. So we built up a knowledge of each other. We know we haven't got a directory of services online that you can access because that's not what our community want. What our community want is that everybody that they ask knows about everybody that they should have been asking. So we might have electronic access to who does what. Well, we've not got anything that is particularly patient facing because it didn't seem to take off when we tried it. So what does working together achieve? I think the two things that stick in my mind are a timely discharge or sometimes not a timely discharge. So because we're a holiday area, particularly the late May and the August bank holiday, the hospital would really like to be empty because it knows that it's going to have an enormous demand from people who are doing stupid things in stupid ways, or who didn't bring their medication, or who didn't realise that maybe that level of stress was going to be too much for them. So everybody who can go home, they will ask to go home on the Thursday or Friday before the bank holiday. And by working together with mental health colleagues, district nurses, pharmacists, GPs, we can look at that and say, can we do this safely? And if at all possible, we will. Particularly, there may be a situation where everybody professionally thinks this person needs to go into a care home, but they don't want to. They want to have one more try at home. So we would then work together and say, yes, this is the combined plan. The district nurse might come with the care home staff, the home care staff to the first visit. And if it goes wrong and they end up having to go into a care home, we're all protecting each other from the inevitable questions from CQC on why did you do this? But what we've done is enable that person to be absolutely certain, and more importantly, their family to be absolutely certain that going home just wasn't going to work. And sometimes we can bring them home and it does work because we're all working together. And very occasionally, when everybody on our side is stretched, a senior clinical member of staff will say to the hospital, I'm very sorry that they can't come home until Tuesday because it's not safe. As a home care provider, I couldn't do that, but by working together, you can. Similarly, admission avoidance, and Tom was talking about delegation. By working together, we've done delegation of remote monitoring and diabetes management, not just in care homes, but actually in home care. They've not been sustainable because we haven't found a way to fund them sustainably yet, but they've happened. And we can avoid admissions. We can go to someone unexpectedly. We can sit with them. We can report back to district nursing colleagues. So we do it, but we don't do it with any money and we don't do it with any framework yet. So we are really hoping that with the new Neighbourhood Health Services, we can really grow this. And I think one of the things is our senior district nursing colleagues treat my home care staff as part of their workforce. And I'm very happy about that. So if they see something that they think needs a little bit of additional skill or a little bit of coaching, then they will just do it. And that's great. And if my staff feel that they're in somewhere where they need some input, they can contact the relevant colleague and they know they will get that input. Thank you, Rachel. Can I have the next slide, please? So if you're going to make the best use of your care providers, I think the things you need to consider is we are part of the resources and we can support the shift from acute to community. You don't need to reinvent us. The other thing I would say is one of the reasons it works in our part of the world is because they talk to us direct. Not all of our customers are commissioned by local authorities, but they are all NHS patients. So talk to us direct, and whether that's independent care sector or VCSE, I think we would all say the same. And by the way, we work really closely together in Lincolnshire. So if you need one of us, we won't send two to a meeting. One of us will go and feed back to the other side. Local authority and CHC commissioners try really hard to help, but they're not providers. So don't just talk to them, talk to us as well. We don't all work in care homes, but they're just as important. They're fantastic spaces for prevention initiatives, falls, hospital admission, things like that. You can do wonderful evaluation because you've got a really nice, clear cohort. Home care teams visit many of your patients. So use us to spot changes that you need to know about. Just ask. It doesn't actually cost any money for us to notice whether or not someone is more breathless than they were. Happy to tell you if you tell us what you want us to look for. Delegate where appropriate and share the plans. I think this is the really key thing. We need to share our plans and therefore share the risks, because we probably in the community don't think we are taking a risk, because we actually think it's taking a risk to let our service users or patients go into an acute hospital at the moment. But the system and the public perceived risks in this shift. So if they're there, we need to share them. Thank you.
Thank you, Melanie. That's really, really helpful and really insightful. I think we've got time for just one specific question about Lincolnshire. So someone's asked, how in practice is risk shared across partners in Lincolnshire, especially for those partners who are registered with the CQC? Any insights on that?
Yes, if we're doing something that appears to be completely unusual, we talk to CQC first, but all the parties involved talk to their bit of CQC. And if something I can't remember the last time actually, things don't go wrong as often when you work together, because you can spot each other's risks and maybe support each other to mitigate them. But I do think when we're looking at something different, we probably don't include CQC in the first meeting, because that might frighten the horses. But if we're going to do something, particularly along the delegation, so when we were doing delegated diabetes management in the community, we spoke to CQC and told them what we were going to do, how we were going to do it, and how it was going to be governed before we started it. And I think that's the key thing, is both sides talk to your bit of CQC.
That makes sense. Thank you. Okay, so thank you, Melanie. I'm going to ask Robin Miller now to talk to us about work that he's been doing, particularly in an initiative, a centre called Impact, which is improving adult care together, and is a evidence implementation centre working in adult social care. But Robin, who is formerly well, still is a social worker, but has worked extensively in integrated care services and has got a lot to offer discussions around this topic. So Robin, welcome.
Thank you. Yeah, thank you, and for the chance to join in the webinar today. Yeah, and I would say, as you set out, I've done a lot of work in relation to integrated care, both as a social worker and as a commissioner in health and social care services, but more laterally as an academic. And I think there's a good rationale for configuring our health and care services around neighbourhoods, because it helps us to address some of the underpinning factors that fragment the way that our professionals and services collaborate together. And also because if we look across internationally, neighbourhood working is one of the initiatives that most countries are starting to invest time and energy in, because it makes sense in their context too. So there's a lot to support the move to neighbourhood working. But as we go on to the next slide, I think in doing so, we have to remember some of the lessons we can draw on from the past. And in many ways, neighbourhood working is combining two previous initiatives, which were already well invested in relation to the health and care services. So the first is the idea of multidisciplinary teams, and it's made sense for many decades that where we've got a population, people with mental health difficulties, people with learning disabilities, people with cancer, in which we've got quite a rich range of professionals and specialisms to support that population, that we try to bring them together into a team so that they can develop better interactions, have better understanding of what each others do, and hopefully therefore communicate and coordinate their care better around the individuals and the families. And so we've got a lot of evidence about what enables MDTs to work and what prevents them in doing so. And some of that's generic to team working in general. So for example, for all teams, including MDTs, we have to have a very clear purpose. Well, why have we brought together these different people in a common team to achieve a common aim? Have we got sufficient diversity of roles? So there's a mixture of skills and experience match what the particular population needs, and is it well balanced? And how is it led? And leadership in multidisciplinary teams is a really quite a complex task. And often what we default to is to the profession with the most status, which currently, commonly in health and social care, will be the doctor. And some doctors are very good leaders of MDTs, but some doctors aren't. And it's quite frightening how little support and development and feedback we give to people who take on such roles in leading an interdisciplinary team in terms of what they could do better and how they could improve it. And also with MDTs, whilst the rationale for them is quite straightforward, actually delivering them in practice is very complicated. And MDTs bring all those historic power imbalances, professional rivalry about who does what and who doesn't do what, and misaligned processes within organisations that we encounter outside the team setting. So the first thing is just to reflect on what we know about multidisciplinary, multi-professional teams and how we can apply those to neighbourhoods. The second is that I think the unique twist that neighbourhoods bring is this idea of more looking at local assets. We know that across the board in terms of health and social care professionals, there's a strong support for us working in a more positive way. So not just focusing on what people can do and providing a professional judgment on what they need to have a better quality of life, but actually thinking about what matters to them and what their strengths are as an individual, as a family member, as being part of a community, and try to complement and not crowd out those informal resources that they have. And the principles are well defined. There's a number of different movements of strength or asset-based working that have come through social work, occupational therapy, nursing, public health, etc. And whilst the language they use might differ slightly, the principles are remarkably similar and have a common set of values. The challenge, though, with asset or strength-based working is how to embed and sustain in practice. Because we have often been trained in a deficit model, because our systems are often based around eligibility and using assessments to define access to services, it is very difficult to actually change the culture and processes within our individual professions and organisations, and therefore doing that across multiple organisations is even trickier. And the final thing is that we've done a lot of evaluations and research around strength and asset-based working. And what you've found in the last decade is that the statutory services, so NHS and local authorities, are trying to own the kind of world of asset-based and strength-based working and saying that, we've decided we want to move to this new approach. And it is great they're embracing it, but in doing so, they can sometimes forget that actually the voluntary community sector, as representative groups or direct deliverers of social and healthcare services, have been doing this for a long time. And whilst they may be consulted, they're not often put right at the heart of decision-making and investments and leadership of these asset-based initiatives. And another commonality I would say that we can learn from the past is that often direct care providers, and particularly social care providers, are often not members of multidisciplinary teams, and they're often not thought about when we're trying to move to a more strength-based system. And it is absolutely vital that the people who spend the longest on a regular basis with those receiving care and support actually at the heart of these teams and this asset-based working. And next slide, please. And that is something we've been looking at in the Impact Centre. And we're not a research centre, we're an implementation centre. So we try and draw on insights from research, from lived experience, from practice knowledge, and use those to help our practice partners to address challenges that they've experienced for some time and to make the most of opportunities. And two of the projects that we've done over the last couple of years, which are relevant to neighbourhood working, and the first was one in Mid and East Antrim in Northern Ireland, where there was quite a successful service run by a local voluntary organisation, which tried to combine sorry, can you go forward a slide, please? Which could was a way of connecting up general practice, pharmacy and social work with local community and voluntary sector organisations. So they would have a project worker that would go out and visit the older person, their family. They would find out what was important to them, and then they would help to match up their needs with the voluntary and community offer. And they brought together those professionals in locality hubs. And they also had a community development approach in that they would work with the professionals and the older people to identify the gaps and then look to try and get investment in the voluntary organisations which could respond to those. And a really crucial thing, I think, within the Mid and East Antrim initiative was that there was a activity-based funding model. So where a voluntary community service supported an older person, they would receive a payment, which would then enable them to grow their capacity to meet some other underpinning costs. And so what we did in the impact project was we looked at what made that project successful, and also looked at how they could further sustain their offer. And previously, before we started working with them, about 80% of general practices were involved. But by looking at the evidence, we managed to raise that to 100% of general practices. And so through looking at the evidence and working out what was it that would enable all those practices to see this relevant. And the other thing we looked at was the inclusion, because sometimes we have this sort of generic sweep of what is a neighbourhood, and we define that geographically. And sometimes we don't really understand the richness of the communities who are contained within that neighbourhood. And we need to do a lot of work in terms of understanding better the data that tells us who lives there, what their particular challenges are, and making sure that we have an inclusive approach. And the other project we've been doing, we worked in Gwynedd in North Wales and in Leeds, who both moved towards developing a locality-based home care model. And in both those areas, they did it slightly differently. What they have done or are looking to do is to develop a model in which a single home care provider is commissioned to provide support for older people in their locality. And they did that primarily so they could address some of those issues to do with workforce retention within home care agencies, and to give the home care teams the opportunity to be more flexible how they supported people. But a really important part of that was by identifying a lead provider. That then meant that they were more obvious contenders to be part of the multidisciplinary teams within that neighbourhood. So it was a really important structural change to support collaboration across the health and social care professionals and the direct care workers. But a couple of insights that we got from those two projects were this. But first of all, changing the contract, so moving from a spot purchase to a block purchase per neighbourhood is a really big task, as you all know. There's a lot of complications there in terms of trying to sort out what the demand's going to be, what a reasonable payment is, and how do you share the risk across the funder and the provider. But even once you've done that, there's no guarantee that things will actually get better. It may provide a platform for improved services and more collaboration, but that won't happen by itself. So having got the contract in place and the provider been selected, you then have to still invest time and energy and facilitation in order to make the improvements. And what we found were particular issues were, first of all, in one of the areas, people with lived experience have been involved in deciding on the contract. But once the contract was let, they weren't really involved in terms of trying to take it forward and improve the service and make sure it reflected what was important to them. So making sure that you carry on with your co-production arrangements, you set up citizens panels and other such supports is really important. And the second thing is that actually for these home care agencies to work differently, their practice leaders have to believe that they've got the mandate to do that and have the leadership support and encouragement in order to enable their staff to work differently. So again, you've got to think about who are the people that can actually make things change on the ground, and are the other professionals prepared and willing to open the door for home care to be equal partners, not to be a contracted service. So there's lots more I could talk about from these two examples from Impact and from other projects that we have, but I'll stop there, Ewan, and hand on to our next speaker, so we've got plenty of time for debate and discussion at the end. Oh, and finally, just to say, there's plenty more information on our website, and just to put a plug out, next April in Birmingham, we're having the world's largest conference on integrated care, and one of our top themes is neighbourhood working. So do put that in your diary and come along and present your good practice examples as well. Thank you.
Thanks a lot, Robin. Okay, so we've got a couple of questions that we'll return to later when we've heard from all the speakers. But thank you very much, Robin. That was really good. Okay, so last but not least, I'm going to ask Dr. Luke Wilkinson, who's based in Liverpool PCN, to talk about what they're doing to integrate health and social care at the neighbourhood level. So it's okay, Luke, I'll hand over to you.
Perfect. Thanks so much, Ewan, and thanks so much for inviting us. So yeah, my name is Luke, and I am a GP, and I work in the ASH surgery, which is surgery in Egbert in Liverpool. And I also am the clinical frailty lead for the SWAGGA primary care network. And I've been asked to have a chat about our sort of care home setup and the enhanced health in care homes. So next slide, Rachel, please. So essentially, what is SWAGGA? So apart from being the catchiest PCN name ever, it actually stands for the geographical location that we cover. So that is Speke, Walton, Aigburth, Gattaca, Garston and Allerton. And it's essentially a collaboration of 16 GP practices, which I've listed there, that are all geographically aligned in South Liverpool. And yeah, we work together essentially to improve patient care. And we have a population of around 100,000 patients. So next slide, please. So I've just put a map of essentially where we cover. And as you can see, that's sort of our area, and there's all our GP practices. And essentially, our area covers 4 neighbourhoods within our network. And so I am sort of the clinical lead for the Frailty team, and we have sort of 5 care coordinators alongside myself who and we have a wider team as well that help support us, and we focus on sort of enhanced health in care homes, proactive care for patients over 65 and above, and just improving the health in general of this population demographic. So next slide, please. So I've put in the top left-hand corner our Aging Well sort of logo that we've developed, and that is what our goal is essentially. And there is 3 tables here. So the first table is essentially a list of our care homes that we cover. So there's 14 care homes and the GP practices that they're aligned to with the patient numbers that I put in there. And we try and aim to keep each care home aligned to 1 GP practice, but there's 1 that is currently being looked after by 3, and we're trying to gradually make that into 1. And essentially, them care homes cover various levels of care, and that includes residential care, nursing, and complex care. And then the other tables essentially just reflect why we are doing what we're doing, and as probably you will all know, how we are an aging population. And essentially that second table sort of been compiled by our colleagues at Public Health, and essentially it was a report called The State of Health Liverpool in 2040. And essentially it predicts that the biggest increase in population is to be expected in patients over 70 and above. And likewise, that second table further sort of strengthens that thought. And that was compiled by the Office for National Statistics, that again predicts that patients over 65 is going to be estimated to have the most increase in numbers in the next decade. So that is why, it's important we focus on this sort of demographic. So next slide, please. So essentially, I'm going to tell you about the enhanced health in care homes. So this originally comes from the NHS long-term plan, and this makes a commitment to sort of focus on aging well and rolling out this programme. And the intended impact of the EHCH is essentially improving healthcare at the individual, the neighbourhood, the place and the system level, with the sort of main focus that people in care homes should receive the same level of healthcare support and treatment as if they were living in their own home. So the objectives that's sort of detailed in the report is that we are to continue to develop integrated, proactive, multidisciplinary teams across all our CQC registered care homes, and improve the health of patients in them care homes, whether they are permanent residents or short-term residents. And the objective is to achieve this by collaborative working with ourselves, the PCNs, the care homes, Liverpool City Council, iMedicare, which is a separate service, which I'll mention later on, and then the wider Mersey Care Services, which is sort of our social services, and to reduce the variation in the health equalities in clinical care across these care homes. So every care home should have, or the requirement for them to sort of engage with this is that every care home needs to be aligned to a primary care network, needs to have a named clinical lead who is responsible for overseeing this framework, and every care home has a weekly MDT, which I will discuss in a bit. And then there are established protocols that are between the care home, the primary care network, and other members of the MDT for clinical issues. So next slide, please. So these are just the 5 main sort of principles of the EHC model. And essentially, the number 1 is personalised care. So making sure that each patient has a what matters to you conversation involving care and future care. The next is co-production and collaboration. So acknowledging the value and expertise of all members of the MDT. And I mean, that includes particularly members of the care home sector, and acknowledging their value and expertise. And everyone in the MDT is considered equal partners. Quality. So we've used sort of research, things that have worked before, and evidence-based approaches to drive this initiative. Leadership, so ensuring there's strong leadership at all levels to implement these MDT. And finally, digital, so making sure we use our technology as best as we can to engage these care homes, share record keeping, and sort of have these weekly MDTs. So next slide, please. So that is all the theory behind it, which is all very good. However, how does it actually work on the ground level, which is sort of more what I'm very familiar with rather than that bit. And essentially, this is all outlined in a service specification, which specifies every role and all the expected sort of procedures. So first of all, new patients and readmissions from hospital of every care home within 7 days should have a new patient pro forma, which essentially I put on the left there, which is essentially a conversation between them, their family members, and their care home about essentially things that they find important in terms of their healthcare, their likes, their wants, and their personal needs. So that is shared then between all members of the MDT and the care home. And then we have a weekly MDT. So who is at the weekly MDT? Well, it does vary from care home to care home, depending on the needs of the care home. But essentially, it is led by community matron, and essentially other people that are involved are the care home manager or a senior carer, a pharmacist, an L or learning difficulties nurse, depending if that's inappropriate for the home, ideally social care workers, a GP, and then our SWAGGA care coordinators, whose role is to coordinate this and to ensure it takes place and to sort of keep the minutes, take the notes, and make sure all the actions are shared and distributed so that everyone has the same record keeping. So every week we will have a brief discussion about patients. Now, most patients in care homes don't have any issues, so it can be very brief. But the main issues we discuss will be sort of just what I've mentioned there. So it's any new admissions, any hospital admissions, any deaths that have happened, any medical attention that have been received since the last MDT, any new issues that care home staff feel are arised, and any sort of follow-up issues that potentially have been discussed last time and to be sort of there was actions to be taken place and then to be followed up. And I've just put on the right there the MDT preparation form, and essentially we ask all care home managers and our senior carers to prepare that prior to the meeting. And yeah, that discusses essentially what I've just mentioned. So next slide, please. Perfect. So this slide I've just put on for 2 reasons. So the first thing is to show you about something called iMedicare, which is essentially a service in Liverpool, or Liverpool Council have commissioned, that all care homes have 24-hour, 7 days a week, 365 days a year. They have access to sort of clinical or advice, and they can just ring this number. So any clinical issues, they go through that, and that is sort of a key part of the EHCH that's embedded. And this iMedicare will have a clinician who can speak to the care home at all hours and triage appropriately. And then the next 2 pictures I've just put in because there is Broughton House, which is the care home in Egbert that I'm the GP on the ward round every week, and I'm a big fan of this care home. I just think they do absolutely fantastic work, and essentially just a population, or there's all good and well talk about population levels, but sometimes individual stories help. And one story I just wanted to share was we had a lady a few months ago who was a 96-year-old lady, and she was Chinese, and she did not speak any English. And the preparation form had been done with her and her daughter prior to her coming to the home. And this included that if she were to become unwell, she would not want to go to hospital. She would not want any aggressive interventions. She would just want to stay in a home, which was Broughton House. And in her likes and interests in that section, it said that she was a really big fan of Strictly Come Dancing. So essentially, we had an MDT, and the care home sort of discussed to us that she was deteriorating. The outcome of the MDT was for me essentially to go and review her end of life care, make sure she was comfortable. And this essentially led to us making sure that she had a very dignified death in her bed where she wanted, with her family around, with strictly reruns being put on iPlayer in the background. And so, yeah, and I know her family were very happy. And that is just a single example of where I was able to get that information from this care, the EHCH model. So next slide, please. So perfect. So I have just put a bit more of a population level data on this slide. And essentially, when we look at 2022 from when we started to 2024, the data shows that there is improvements being shown in terms of how many inpatient beds from our care homes. There's been a 61% reduction, and there's a 21% reduction in A&E attendances. And then when we've looked at the data via Aristotle on the inpatient cost, that has actually reduced in 76% of the care homes. Now, one thing that I wanted to sort of mention that I can't really put in a number is another benefit is the sort of neighbourhoods collaboration and the networking relationships that you build through this process, that, you know, having these relationships just have massive benefits in lots of other ways, aside from in other healthcare and other parts of my sort of GP work. So yeah, that is another benefit of this scheme. So next slide, please. So I just wanted to very briefly mention other things that we do in SWAGGA and our frailty team. So essentially, we're quite big on proactive care, which is sort of making sure we see people and jump in with healthcare interventions before people become unwell or need to go to hospital. And so I'll just whiz through these photos. Essentially, we had a Christmas fun day where we had a sort of knit and natter group organised to come, and we had sort of Father Christmas, and we had school kids come and sing, and we did sort of these aging well sort of clinics while we were there. So we had 50 patients who we did sort of a pro forma based on something called the CGA, which is clinical geriatric assessment, to sort of clarify if there was any risks that needed interventions. And then we've done osteoporosis projects to try and clarify and increase the incidence of this so that we can act and offer bone protection before anything, before they fall and break their hip, for example, requiring hospital intervention. The next photo is our happy place. So we have worked with a local solutions, which is a charity in Liverpool, and essentially we are we've been organising in the neighbourhood of Netherley carers and patients over 65 to be able to come to an area, and it's essentially a knit and natter group, but we do have people come and do strength exercises and health awareness talks there as well, and that's shown improvements in clinical frailty measures such as Rockwood scores. Through the relationships we have gathered through this process, we implemented a flu vaccine distribution throughout the care homes. We've done other neighbourhood pop-up events, including sort of Christmas decorations for patients in care homes and got family members involved. And we had a Valentine's Day event in Netherley as well, where we put on a coffee morning for 50 patients over 65 and had a singer, and also offered our aging well sort of proactive care clinics while we were there. And even the mayor of Liverpool got involved and came to see us. So yeah, that's just a brief chat about what we do. And next slide. So that is it. So thank you very much for inviting me and having a chat. I put my email on there because I know there's probably a lot of questions about all the other great talks. So I'm very happy to anyone to contact me if needed. So thank you.
Thank you, Luke. That was really inspiring. What you're doing there seems to absolutely embody what neighbourhood health should be all about, really, which is, so it's fantastic to see that. Actually, I've got a question before I move to broader questions for the rest of the panel. I've got just a question here for you, Luke, about how do you support people with frailty but who have also got profound and multiple learning disabilities? Is there anything different that you do with that group?
Yeah, well, so we do have so I'm sort of the clinical frailty, and we do have a mental health sort of clinical lead as well. And our sort of roles with them types of patients do cross over, but we do put on clinics. So every year, everyone who has a learning difficulty, regardless of age, will have sort of a proactive healthcare check. And that essentially includes a lot of sort of very specific things to learning difficulties, but also other sort of just healthcare needs of frail patients, essentially. And yeah, so they get annual reviews, and actually we're doing projects as well. They're doing projects as well to sort of make our GP practice a bit more accessible and have sort of certain sensory initiatives to make it a more accessible and comfortable experience for that cohort of patients. So yeah, we are absolutely doing work on that there.
Thank you very much, Luke. And just for me, it's very impressive how far you've grown this across your area in Liverpool. If you were to take this approach and try to develop it in another part of Liverpool or another city entirely, how might you start going about that? Because that's one of the problems, is how you scale these really good interventions so that more people can benefit from them. What's your thoughts on taking this elsewhere and growing it elsewhere?
Yeah, I mean, I'm a big fan. I don't know if that came across in the talk. I'm a very big fan of this model. And yeah, and it didn't happen overnight. I completely will admit that. And yeah, there are barriers, and you've got to start, make sure everyone's on board and build them relationships, go and see people in person and go and speak to people. You know, I think that was one of the things when we were setting this up, to make sure they have a face, they understand everything. And we have a sort of a specification document that is very clear on everyone's roles in this, and making sure that there's no ambiguity, and people are clear on why we're doing this. You know, this is based on a pilot we did in another care home in Liverpool that showed these benefits, outlining that to people, and then essentially, yeah, just being clear and making sure that everyone understands their roles and know who to contact in certain situations. But yeah, I mean, this has taken, you know, a few years to really get up and running in our network.
Fantastic, thanks, Luke. So just bringing in Robin, if that's okay. There's a question about asset-based or strengths-based approaches and how you avoid that approach becoming a way of rationing services, and we're working in obviously very difficult times at the moment financially. So just any reflections on that? Question.
No, thank you. And so, I mean, the first thing I think is a good concern to raise, because when you speak to people who access services and families and indeed voluntary sector organisations, they're really concerned about this. That what we're doing really is we're cutting investment in social care and related services, but we're trying to whitewash that or wash that in a kind of a language of strength-based or asset-based working. I think, though, it's not a question of, I don't think we can avoid the fact that actually commissioners have to find more effective and efficient ways of investing their resources. And therefore we can't ignore the need for more preventative supports that enables public sector and indeed people themselves to use their finances and funding more effectively. So I don't think we should therefore have it as a dichotomy of it's either about improving well-being or it's about ensuring that services can use their money more effectively. I think it has to be about both those things. And what we have to do is articulate that very clearly, because when people become very skeptical, understandably, is when they're told it's about improving well-being, but actually, from a commissioner point of view, there's a great anxiety about, can we also save money from doing this? And I think what we need to do is a very transparent conversation about the potential benefits. Something we often use in integrated care is the notion of the triple aim, where it's about addressing inequalities, it's about improving individual experience, but it's also about using money more effectively. And I think that's quite a helpful structure to say, we need to be aware of all these things, not have one area take the priority and be the actual test that we use, but be quite clear about all those factors. And then we can have a much more open, transparent, robust conversation about what we're trying to achieve from these initiatives, and then make sure we evaluate and monitor accordingly.
Thank you, Robin. So just bring in Melanie, actually, because Robin, you mentioned the research that's been done on new models of home care and this idea of having a lead provider in a locality. And then Melanie messaged me about that being also the case, the model that's been adopted in Lincolnshire. Just be good to hear your views, Melanie, and why you think that model might be a good one for locality or neighbourhood working.
I think it's quite interesting because it kind of segues from the last question. It does save shed loads of money for the local authority. Lincolnshire has probably the most extreme lead provider model, in that the county is split into 11 zones. In that zone, all of the home care is the lead provider's responsibility. If I don't have the staff to provide it, I can subcontract it. If I can't subcontract it and they end up in a short-term care bed, I get the bill. Trust me, we don't leave anybody in short-term care beds that shouldn't be there. So it does work. But when we first looked at the contract, Ewan, it looked horrendous from a provider point of view. But actually now there are only 9 of us to talk to the local authority. And so the power balance switches. You have to have an adult to adult conversation because neither of you can afford not to. So I think that, and it really has worked. There have been times when we've had some uncomfortable adult to adult conversations, but they've always been at that level. We've treated each other with mutual respect. We got through COVID incredibly well. So I do think we don't exclude other providers. We have to subcontract at least 10% of the work to maintain the local market. But I think if home care provision hadn't been too expensive within local authorities, they would never have outsourced it. And the properly introduced prime provider model is outsourcing what they did before, not chucking it all up in the air and saying, which bit do you want? So I think when home care was outsourced initially, it wasn't outsourced. They completely changed the model. The prime provider model goes back to outsourcing. So I have to work with my adult social care team. They have to work with me. But they sometimes used to fall out with the care coordinators when it was in-house. You know, I need 25 hours in 10 minutes. Well, you can't have it. What do you actually need? So I do think that model is just going back to what they were originally trying to outsource. But I think that also goes with the same thing. It does save money, but that wasn't why they did it. They did it because it wasn't working. And I think the same with strength-based or asset-based care. If you take a self-funder and say to them, if we focus on the things that you can do and only sell you the bits that you can't, that would not be considered rationing. It would be considered responsible selling. So I think, again, we need to have a conversation that says it's not about rationing, but it is about making the most of what we do and the most of what we've got. But hopefully that should save money. If my care staff can do something that Luke was doing last week, that will save money because he's a lot more expensive than my care staff. But if we do it right, it will also mean that Mrs. Miggins only has to put up with one of us walking through the door, because in an ideal world, she wouldn't see any of us. But I just think we need to develop the integrated strength-based models between practitioners and then tell the commissioners how they can save money by implementing it. And at the moment, it goes the other way. We've just started talking to our Primary Care Network Alliance and our local medical committee and saying that actually it's much better if we work together and say, well, if we did this and this and this, patients will be happier, waiting lists will be shorter. And by the way, commissioners, you could probably save some money.
Yeah.
Because then you don't get the cynicism of they're only trying to do it to save money. Tech is a big example. Putting tech into people's homes I don't think should be used to reduce the amount of home care they have. It should be reduced to enhance the home care. So if you need something in between, you can shout, but then you might be able to drop 1 out of 4 calls safely. So I think it's about not just letting the commissioners decide. We've got to get the MDT, and maybe that comes out of neighbourhood working. Maybe the people who should be worried about how they're placed in the MDT, or maybe we should be putting them in there as well. Should the commissioners be somebody we talk to? Because we tend not to. We either talk to them or we talk to each other. And for this to work, maybe they have to be at the table too.
That's really good suggestion, because I think there's still this big divide sometimes between commissioners and the people involved in developing, delivering social care. So I think that's an interesting question that you pose there. Thanks for that. I mean, so money has come up again in one of the questions. It's unsurprising given how tough it is out there. But Luke, someone's asked, out of curiosity, does the PCN have any additional local funding for this work? Any kind of way in which you're using money differently to make it go further?
Not particularly. Essentially, because there's multiple people involved in this area. So from the PCN, we have sort of the R's roles, and the PCN DES is where we get our funding from. For various things we've done sort of collaborations with that local solutions that I mentioned. But in terms of the EHCH, Mersey Care, sort of an organisation for which our community matrons work for, and they're sort of funded for that role, to sort of, they're the clinical lead of these care homes, ward rounds. So not particularly any magic money popping up from anywhere, other than sort of collaborations and from the council and the DES and the R's role.
Thank you, Luke. It's really helpful. So the question for Melanie, given the highly fragmented nature of the home care provider sector, will scaling the model of contracted providers working together on a neighbourhood basis potentially see other providers coming out of the market and reduce the number of providers that local authorities have to deal with, whilst saving money and improving efficiency? I got there in the end. Any thoughts on that?
I think there are lots of things suggesting that there should be a consolidation of the home care market at the moment, Ewan. I think one of the responses to the financial challenges from the budget is maybe there will be less providers. There was also a massive increase in the number of providers when international recruitment came onto the patch, and that doesn't entirely work either. When we went to the initial lead provider model in Lincolnshire, the council supported us with working better together, collaborating, and in some cases actually taking each other over, but in other cases just staying as that collaboration. And I think anybody that is, whether it's an NHS, an ICB, or a local authority that's looking to make better use, there needs to be some joining up, because we still have situations where carers wearing different uniforms walk past each other in the street. I know that's choice, and you can either go to Aldi or Lidl if you like, but we're not in that world. We don't have enough workforce to waste time with 2 companies going to the same place. So that we have to, and I think that's something that we, maybe through the Care Provider Alliance, maybe something the sector needs to step up and say, yes, we are in competition, but we are not in competition with each other as much as we are in competition with not being able to provide the right health and care services for our citizens. That's the big rival. The other stuff is things that we need to be able to work together, but maybe that's us as a sector, Ewan.
Yeah, and just to add to that, I mean, it's interesting, in Gwynedd, which in North Wales have moved to a locality-based model quite a long time ago, they deliberately commissioned it that a third of the localities were led by local authority home care, a third were led by private home care organisations, and a third were led by voluntary and community sector organisations, which I thought was quite a clever way of making sure that there was still a sort of equality of contribution, diversity of provider types within their area, while still having a single organisation leading for each area. And I suppose the other thing to think about, just to remember, I think everybody in the call will know this, I'm sure, is that a huge amount of home care is funded privately. also. So therefore, we're thinking about kind of a market. We're thinking about this is the public sector funded market, aren't we? And there's still opportunity for providers to develop new opportunities to sell themselves and their supports to people who are paying for it, and through their own pockets, through their families, etc. So it's not taking away from the market altogether, but equally it's stewarding that market in a way that's more sensible and better for the providers as well, as Melanie set out quite eloquently, I think.
Thank you. Well, look, we're almost out of time, so just a few thoughts from me at the end of this lively and really fascinating discussion. I've certainly learned a lot from it. So clearly, first of all, there's a lot going on already. Some really good practice going on in Lincolnshire, in Leeds, in Wales, in Northern Ireland, in Liverpool. So we know that good work can be done and is being done. And to add to that, there's also good evidence. Robin discussed some of the examples of good evidence out there. Use that evidence. There's a lot of research that's already has been done and it continues to be done on neighbourhood health. So have a look at that. I think the other message for me is think very broadly here. Think communities, think the assets within communities, think about housing, think about pharmacy, think about allied professionals, all of the different people that need to be involved in building a thriving and well community. And relationships absolutely seem to be at the heart of every successful example. Luke's example, the examples Robin was giving, Tom was giving right at the start about Leeds, Melanie was giving when she was talking about Lincolnshire. So relationships seem to be absolutely the heart of it. And actually, if you back each other up, you support each other. And I love that example, Lincolnshire, of people almost training one another when the needs arise. I think it's just it's an amazing way to work. It's just giving each other cover and support in what are really difficult and challenging times and difficult roles. So those were the key messages for me. I'm sure you picked up other really interesting messages as well. So we will be circulating the recording and the slides from today. I think we can circulate people's emails if you want to get in touch with Rob and Luke and others. We'll do that as well. And just want to thank everyone. Thank Tom, Luke, Melanie and Robin for your contributions today. And hope everyone has a lovely weekend when it arrives. Thank you very much, everyone. See you soon. Cheers.